I'm going to kick us off as we go in, introducing myself. I'm Sam Roworth. I'm the head of behavioral health at EverHealth, which is EMHware. So EMHware is probably one of the most utilized client management systems in child and youth, as well as addictions across the province. Uh, and I enjoy spending a ton of time diving in deep with our clinicians and our organizations. And I'm going to kick it over to Nora, and we'll go across in order as folks that are presenting will introduce themselves. Over to you, Nora.
Hello, I'm Dr. Nora Klemetzik. I am the lead clinical psychologist at Child Development Institute, and I have had the pleasure of leading our implementation of MBC at CDI over the past year and a bit.
Fantastic. Lori?
Hi, everyone. I'm Lori Marsan, and I'm the Director of Clinical Services here at CDI, and I'm working very closely with Nora, and it has been an exciting journey that we'll share with you today. So thank you for joining us.
And then we'll wrap it up with you, Simon.
My name is Simon Weiss. I'm the president at Greenspace Health. It is a fancy title. Functionally, what I do every day is spend time with partner organizations and prospective partners thinking about measurement-based care, designing workflows, thinking through clinical challenges, trying to work out how to best understand and utilize the data that's coming out of it. So really excited to share more today and kind of in line with most of my conversations, dive deep into MBC.
Fantastic. Thanks, everyone. Just for a quick background and how we're going to structure today, we're going to do just a quick chat through why EMHware and Greenspace partnership, and why we both kind of chose each other to have that marriage and really dive deep together. Then going into a deep dive on MBC, followed by that practical storytelling of CDI's MBC journey. And then we'll be able to wrap it up with some Q&A from everybody that's listening today. So as we jump into like why EMHware and Greenspace, there's lots of different client management systems out there. There's a few, not as many, MBC platforms in the market. But we've been talking, and Simon and I have been chatting about this for several years as we figured out why we always felt such a connection between our organizations and the missions of both orgs. And we realized like we're both the leading providers, and we like being at the forefront of how can we impact the outcomes for clients and building strong communities. And that can't just be by software. So we both organizations have very much a people first approach. And I'd say that's the feedback that Simon gets on his teams and I get about the EMHware teams is people really love our people. And we really have deep relationships with our clients and the folks that are on the ground and the real experts that are having that immense impact on our communities, especially the people that are most vulnerable. We take the approach of customer service comes first. And when we make commitments, they come first as well. And that listening to our clients really helps shape some of the product vision and tying together that clinical experience to make sure that it's not going to be a burden on our teams, that we're making this integration of two systems very user friendly, and that you almost don't notice there's an integration because it's so seamless. And I'm really excited as Simon dives in deeper in some of the announcements we have over the next little bit that folks will see it's like, oh, here's where I do my work. I can focus on the client in front of me. I don't need to focus on following a million different steps and jumping around. And that was really important as we looked at how do we design this and make sure that the clinician and client and their clients are right at the forefront of making this valuable on how they can deliver care. And for us, it's really about that collaboration and better outcomes, less so about us just making cool software. That doesn't do it for us at either organization. It's very much how do we make the clinical experience better, because in turn that's going to make the client experience the best it can be. So before I hand it off, for us, it's really about how do we embed these two tools together. The efficient workflows, smarter care, and better outcomes really need to be the center of the conversation. And I'm really excited to be able to hand it over to Simon as he does that deep dive into measurement-based care. Over to you, Simon.
Thank you, Sam. And even before getting into it, a couple points you made, Sam, that I'd love to echo. Like, number one, you use the word impact and this opportunity that EMHware and Greenspace have as leading kind of technology providers in the sector to be able to together scale the impact of this work across our partners and shared partners. And so that to me is really what's exciting. Like, we got into this to be able to have an impact on um, your organizations, the clients that each of your organizations serve. And so the ability to scale that impact through partnership is really important to our team, and I know it is to EMHware as well. Um, and then the other piece, Sam, you mentioned is product vision. Like, I think one of the underappreciated elements of partnership is the opportunity to think about the integrated experience as an evolving product, right? As opposed to saying, hey, let's deliver integration once for a single partner. Um, get to think over a 2 to 3 year horizon. And Sam mentioned it, but there's sort of a pretty meaningful change that's coming to the integration that we believe is going to have a major impact on clinician workflows that has been a year plus in the making and taken a lot of work between both teams. So we're excited to share more about that, whether it's on this call or another time. And let's dive into measurement-based care. And it, we'll start with the quick background on Greenspace Health. I'm sure some of the folks in this call are familiar with our team. I know we have some shared customers that have joined, but for those that aren't, Greenspace is an organization that was originally founded out of St. Michael's Hospital in Toronto. And the goal from day one was, how do we bridge this gap between clinical research and clinical practice with respect to measurement-based care? An evidence-based practice that has been in the literature for a number of years, has been clearly demonstrated to impact care positively, has been demonstrated to impact organizational outcomes overall. But certainly 10 years ago, like, adoption of clinical practice was pretty limited. That has certainly changed in the last 10 years. And we've been really excited to see Ontario as one of the leaders across the country, in particular in our home base, but nationally. I think we're seeing Canada now as one of the leaders internationally on pushing towards measurement-based care, pushing towards better data from mental health and addictions treatment. Today, we're now supporting over 500 organizations with measurement-based care. Our data set involves over 8 million assessments completed. It is now the largest data set on measurement-based care in North America, which further allows us to deliver, I'd say, value to our partners, particular in terms of being able to set national benchmarks for different kind of levels of care and help organizations understand where there's opportunity to continue pushing improvement. So excited to dive a little bit deeper into, call it the MBC 101, but hopefully this background on our organization is helpful, and gives you a sense that everything we do, everything we think about is focused on measurement-based care, and ultimately how do we support improving client outcomes in mental health and addictions treatment. So what is measurement-based care? This is a definition from a 2015 paper that I find pretty clean and easy to understand. The routine collection and use of client-reported progress measures throughout treatment to guide clinical decision-making. To me, the element of this definition that always stands out is guide clinical decision-making. A lot of organizations, I would say, start investing in measurement-based care with a goal of generating outcome data. And we'll speak about that. But ultimately, the core definition of MBC is focused on the client-clinician interaction and the impact we can have on the clinical work that's happening in session. Now, I'll use a bit of a compare and contrast here in two visuals. I find this helpful to understand what measurement-based care looks like in the research and should look like in practice. For most organizations that we partner with, their use of assessment tools kind of looks like the graph on the left here, the current state. Often teams are pretty good at capturing a tool at the start of treatment. It's often part of biopsychosocial and intake. So you might be getting 1 or 2 assessments done at the start of treatment. And then many teams are attempting a pre and post model The workflows are pretty manual. And so we see a lot of challenges with adherence to completing follow-on measures from a clinician perspective, but also you don't always have an agreed upon end state to treatment. So when we come in to work with an organization, we like to look at the existing data set and sort of set goals and KPIs related to that. And um, the average that we're seeing out there in the community is about 1.25 assessments completed per client. And so when you think about that, it's hard to imagine that impacting clinical care and client outcomes, but it's also not a path to capturing meaningful outcome data. So when we think about the shift to measurement-based care, it looks more like the graph on the right, where you're capturing measures across multiple domains consistently throughout treatment, as I said, to guide clinical decision-making. And ultimately, not only are you getting a richer data set, but you're changing the trajectory of care. And across Greenspace implementations, we're seeing an average of 14.7 assessments completed per client. So the difference is pretty drastic when we start to truly invest in MBC. And I know the CDI team will speak quite a bit more about that journey and their experience. One other way that I find helpful to define MBC is using this concept of the 4 C's. So what does good MBC look like in practice? We want it to be consistent throughout care. We want to shift away from that pre and post model that I referenced. We want to customize the measures used to the presenting issues, symptoms, and goals of the client. Right? If we're not measuring symptoms or functioning or elements that are relevant to care and the conversation, it's not going to be particularly useful to client or clinician. We want to be able to visualize results and provide insights back to clinicians and clients. And we want to ensure that this is a collaborative model between the client and clinician. There's definitely an important element of MBC with respect to client empowerment, client engagement in care. And we see that in terms of even no-shows and cancellations being impacted pretty meaningfully when this is done well. So the next slide here is sort of, we've done the what is MBC, but let's talk about why it matters. And I've really summarized this into 3 categories, and I would say these are the 3 main drivers behind an organization choosing to invest in measurement-based care. By far, the number 1 driver of an organization investing in MBC is outcome data. And this is the path in mental health and addiction services to understanding outcomes, having rich data on what's happening in care, and being able to adjust and improve services based off that data. So there is the internal use of it, which honestly is normally the primary driver. How do we better understand what's happening in our services, understand the impact we're having for different client populations through different levels of care, and adjust? There's also the external use of outcome data. So how do we use this data to demonstrate our impact externally to stakeholders? That might be funders. It might be as part of writing grant applications. It might be to board. It might be to other stakeholders. The next, I'd say, most common driver would be like impact on client care. So there is a ton of research on the impact that measurement-based care has on client outcomes, as much as a 42% impact on symptom improvement. But some of the other ones I listed here, I say often stand out. I've already referenced client engagement. Strengthened client engagement really has a direct link to return on investment for our partner organizations as well. So in outpatient settings, we're typically seeing around a 20% impact on no-show and cancellation rates. And so we can sort of flow the calculation through, but for a typical, call it a $5 million service line, that often equates to over $100,000 in net new revenue by reducing those no-shows and cancellations. For clinical leaders and managers and supervisors, access to real-time data that gives them visibility and oversight into what's happening across programs. And then we see this a lot in the sector where organizations with wait lists can improve their flow through services, right? Understand when to step up and step down care based on client reported information, and ensure that folks are not in a service for 2 years. And if they're not seeing improvement, we might want to step them up. But if they have improved, we want to step them out to be able to make space for folks on the wait list. Then the last piece is there's sort of an increasing trend towards requirement of measurement-based care, whether that's within grants or provincial funding streams. The examples below here are Ontario Structured Psychotherapy, PPM 169 in school boards, but there's a number of others. And I think we're starting to see the Center of Excellence out of Ontario Health hint at a shift away from requiring measurement-based care within new funding initiatives towards in the next year or two requiring measurement-based care within existing funding streams. So this is the direction of the sector. We've seen health authorities across the country make this shift, and Ontario Health is definitely pushing in this direction as well. So our role with partner organizations is to set them up to succeed and ensure that not only do we have measurement-based care in place and operating successfully, but we're using that data to consistently improve care and improve outcomes. So every year we're sort of in a better state as an organization. I'm going to move on to I think what is my last slide here before we turn it over to CDI. And I don't want to get too much into like Greenspace product and Greenspace solution. Like, happy to take questions on that. We can obviously set up time outside of this conversation. But I think it's relevant just to give a bit of an overview and set a framework for Lori and Nora speaking through their team's experience. And when our team sort of thinks about what's important, like what are kind of the core fundamentals around how we're enabling measurement-based care and making this easy for partner organizations, I'll talk through a few elements. So number one, as I mentioned before, you want to be using assessments that are the right fit for the clients and programs that you are operating. Our approach is we want to be agnostic to the measures that our partners are using. Greenspace needs to be an infrastructure to enable measurement-based care, not a prescriptive solution. So we've got an assessment library. There's 500 plus measures in there. We could also add others. It really is about meeting an organization where they're at and addressing the sort of clinical needs that they have. Number two, we want to remove clinician effort. We want to be able to drastically reduce any manual, I'd say reduce or remove any manual steps that clinicians need to take to assign measures, set up workflows, and the integration between EMHware and Greenspace accomplishes a lot of this. We have partners that kind of rely on that integration for 90+% of the steps that otherwise would have been required for measurement-based care. The next piece here is engaging clients directly and making that really seamless. So multiple options for completing measures, removing barriers like no account creation, no sign in to complete measures, allowing these to be done remotely or in the waiting room or in session, really making this easy to engage clients. And then we talked about removing clinician effort or reducing clinician effort. This next piece around visualizing results and insights, I think about that as bringing up clinician value. And when we think about implementation, there's definitely an equation there of effort versus value. And so we need to be able to deliver value to the clinician and make it easy for them to bring this into their clinical care, to integrate this into their conversation. So that's a big thing that our team spends a lot of time thinking about. And one of the kind of the data points that I get most excited about in our data set is the strongest correlation that we see between measurement-based care and outcomes is tied to clinician use of results. So clinician engagement with visualization of results and insights is very strongly correlated to outcomes of clients. So that's ultimately the core activity we're trying to incentivize and drive. And so when we're making product decisions, we want to ensure we're enabling that value for clinicians. And then lastly, analytics, they need to be configurable. They need to meet sort of the goals of your organization. And ultimately, there's a whole host of different use cases that we'll see on the analytics side, whether that is caseload management, looking at who might be off track or presenting with risk in a specific program, looking at outcomes and breaking that down by SDOH factors, sort of a range of use cases here. But from our perspective, this is sort of a framework to be able to enable value beyond the client and clinician. So managers, supervisors, leaders, data and QI folks can really engage with this data as well. So hopefully that's a helpful overview. I would love to sort of turn it over to, I think, the more exciting part of this conversation in the Child Development Institute's journey. So I will stop my screen share and I would love to turn it over to Nora and Lori to take this group through the rest.
Okay, thank you very much. I'll just get our slides ready here to share. Lori will start us off though. So I'm gonna bring us here.
Okay, there we go. So I'll start us off just to give you a little bit of a highlight of our agenda. We'll give you an overview of who we are, CDI. We'll talk about measurement-based care, a little bit of the background and the implementation, the next steps, and the key learnings. So I'll start off by just telling you a little bit about who we are. CDI has been around for more than 100 years, and we are an accredited children's mental health organization based in Toronto. And we have a mission to support the healthy development of children, youth, and their families. We have three streams as an organization. We have a child and youth mental health stream, gender-based violence services, and early years and childcare. And just to tell you a little bit about our impact in this past year, we have served over 17,000 children, youth, and families, and this is across all of our service areas. One data element we're quite pleased and proud about is 97% of children and youth in our clinical services, Ministry of Health funded programs, have reported positive outcomes at the end of their service time. We've also expanded our reach, and this, to give you some background, includes both of our childcare and our children's mental health, but also we have some CDI developed programs that we have scaled, and we have organizations that we call affiliates that are actually implementing these programs, and that is nationally and internationally. So we're really quite pleased to see the growth in that area. And the other focus areas is workshops. We provide workshops to the general public on learning disabilities and mental health, which is one of our specialty streams in child and youth mental health. And also in our childcare centers, we have a childcare consultation team that provide workshops to childcare. So some really good metrics there. So to tell you a little bit about measurement-based care, the vision really started with building on our longstanding culture as an organization. I would say this is part of our DNA, and it goes back years, of program development, innovation, and evaluation. And our vision was to take it a next step to use evidence-based tools in our clinical work to demonstrate positive client outcomes. And Simon just gave a nice overview of the merits of measurement-based care. And anchored in our vision, mission, and values to transform the lives of children, youth, and their families through innovative and impactful services. And the impact is exactly, the driver here. We were committed to measurement-based care at a client level. And in order to support this, we envisioned a client information system that had an integrated measurement-based care features within it. So a little bit about the background, how we started. We actually were in a place where we had to change our client information system. So we put out an RFP process in 2023, and we chose a joint proposal that was submitted by EMHware and Greenspace for an integrated system. So we launched our EMHware platform in 2024, and it was followed by Greenspace launch in early 2025. We also were very fortunate to have partnered with Capitalize for Kids. They have provided us tremendous support around project management. Capitalize for Kids, for those who don't know, is a charitable organization dedicated to improving Canada's mental health system. And the other is that CDI is our organizational senior leadership is very strongly behind this as project sponsors. And we have key leaders in our clinical services department, Nora being the pivotal person driving this moving forward. So why MBC? Again, I think Simon spoke to this, very compelling case to be made for why this is important. It demonstrates outcomes, so it does really give you concrete ways of demonstrating your impact. Accountability in terms of really demonstrating, the work that we're doing. Client engagement, again, the therapeutic alliance, the joint decision making, really involving our clients in the process. That is so powerful. Supporting the client work. And again, Simon spoke to some of this earlier in terms of it really enhances the assessment and also your treatment planning. And it also helps to identify when you might need to change course in your treatment plan approach. And the other is the professional development. I mean, our clinicians are learning. It's so dynamic in the day-to-day, using these tools, reviewing what the results are telling us, using regular feedback with clients. And in terms of the quality of their practice, it is so enhanced when you're using measurement-based care tools. So I will turn it over to Nora.
Okay, thank you so much, Lori. So yes, it's my pleasure to talk today a little bit about the journey we've taken so far at CDI for implementing MBC. And I can say personally, I was sold on the idea of using MBC. I think there are so many merits, and there is a good evidence base that MBC can be really quite helpful in the mental health services sphere. And looking at CDI's programming, though, it was a bit daunting because we do have a real diversity of programming. I don't think that's unique to child and youth mental health centers, really. Many of us have a diversity in terms of the intensity of services we provide, the populations we serve, even in terms of ages, developmental stages from birth to age 18. Much goes on during those years in terms of development. And also just the types of concerns and populations that we serve. There's such a diversity that it did feel a bit daunting to me when I was first approached about this idea of being a leader in the implementation. It really took a lot of thoughtful planning, I would say. And when I look back to the early stages of our implementation, I think the first stage we went through, I would say, would be a monthly educational session that was led by a team of psychologists that we have at CDI. I'm very lucky to work with a team of psychologists. And so we took turns and supported each other in providing some educational sessions to the staff about, first, not actual MBC, but first just how do we look at measures as providing utility or adding or enhancing, adding to or enhancing our clinical work. Many clinicians aren't necessarily trained in using measures at all. So the idea that you might use measures to enhance or support clinical work is a little bit foreign to some clinicians. And so the first thing we wanted to do was talk about the measures we're already using at CDI. And Lori alluded to this already, that we actually have quite a long history of using measures at CDI, but we've been using them a little bit more in the way akin to how Simon was talking about in his visualization of pre and post measures, or starting, using a measure for an assessment purpose, and perhaps 6 months later checking to see, should we change course in our treatment now? But we weren't really using measures in a regular routine kind of collection way. And so the first step, though, we thought we'd take was to just have clinicians feel a little bit more comfortable in using measures that we already are collecting for purposes of intake assessment or for purposes of program evaluation and monitoring as a big picture how things are going. And that, I think, did open up conversations and help our clinicians to feel a little bit more comfortable and interested in using data that you can gather from standardized measures, and understanding a little bit more about standardization or norm reference measures. What can they tell us? Also, what they can't tell us. We talked quite a bit about, we can't be, making diagnoses, obviously, or using this information as our only information when we're making clinical decisions or guiding a treatment plan or goal setting, things like that. As we kept talking about how measures can be useful in a general way in terms of for other purposes other than MBC, we also started introducing the idea and concept of MBC. What is it? Why could it be helpful to us in our setting? And that continued for over a year. We were doing monthly educational sessions and had lots of great conversations with our clinicians across all of our different programming in clinical services. Then our next step on my bullet here about the 2024 to present was to gather a working group, we called it, and to put together a smaller group, about a dozen of us, to get together regularly to talk more in depth about MBC and how we might see it playing out or being used in the different programs we have at CDI. So that working group constituted a few of our evaluation research team, some of our psychologists, some of the staff, the clinical staff and managers from across different programs. But it wasn't all of our clinicians. It was just a smaller group that was getting a little more in depth into what is MBC and how could it be used at CDI. And we're still doing that, although it's not monthly. We used to be meeting on a monthly basis. Now we do it quarterly, and we still do, exchange information and learn from each other about how we can use MBC in the best way, even though we might be serving very different populations and have very different kinds of programming. We can still learn from each other about how to do this. Okay, so then again, as Lori was alluding to, it was last year, just about a year ago, when we first started actually using the integration between Greenspace and EMHware, and our clinicians just got their feet wet a little bit with understanding how this integration works and how the platforms can be helpful. The best evidence, and also we had the iPads purchased to facilitate completing the measures through Greenspace during in-person meetings. So much of our work clinically with children and youth is on site. We know that they're a little bit often less engaged virtually, so we really do most of our clinical work with the younger population on site. And so having a way for them to easily, do their measures or fill out measures in a routine way, the iPads were a great way to do that. And then the phased implementation of MBC across programs. I'll just talk about this a little bit. We had to make decisions about how we were going to, in our working group, we were trying to make decisions about how are we going to implement this in a way that will be the most sustainable, that will help clinicians see this as a value added to their work and not as like another administrative task that's kind of being piled on. And so when we started talking about where we wanted to start at CDI, we did look at evidence in terms of where does MBC show the best evidence? And it really is in that area of individual treatment or therapy where someone can self-report about their own symptoms or functioning or whatever domain it is you're assessing. And so we really had one program that did provide individual therapy to youth ages 12 and up. And so we started with that program and we said, let's get going with this program first, because that's where our evidence is strongest in terms of MBC's effectiveness. And so that's what we did. We started with this program last year, about around now, and had our youth-focused therapists start using measures, an actual protocol of measures with all of the youth that they saw that were between 12 and 18 years of age in the individual therapy. That went quite well. Like there were bumps to work out and, things along the way that we've been continuing to talk about and work out. But in general, that was quite successful. And our next program or our next phase that we looked at was another service that provides individual counseling and therapy. But this time it's for very young children, 0 to 6-year-olds. So really the focus is with the parents, because we're not having our 0 to 6-year-olds fill out measures. That would be not really evidence-based, but so we would have the parents of that population fill out measures for us when they were doing individual therapy, because they have an individualized treatment plan, and reporting on what they see in their child, but on a regular basis, routine way, not simply at the very beginning of treatment 6 months later. So that was the second program we looked at. Then finally, the third program that we've looked at so far, or been implementing MBC in so far, is our newest, very new implementation. And this is a service that has at its core a standardized group intervention. And so we really puzzled about this one because you can't just decide, okay, well, this person's not responding really to group 5. Let's just do something different in group 6. It doesn't really work that way. It's an evidence-based standardized group. And so what we were trying to puzzle with or look at for this program was, how do we introduce session by session or routine measurement collection in the components of this program that are more individualized. And so right now, what we're very early stages of starting is using session by session measurement with the children or youth post programming or post group programming, typically when they would be having some more individualized sessions together with their therapist.
Nora,
Yeah.
want to jump in before we move to the next slide. I'm curious, in phase 1 and 2, where this has been rolling out for a number of months. Are there any stories of specific stories or areas of impact that you can share in the kind of 12 to 18 youth population, and what it meant for their engagement with care, and or in phase 2 with parents, and sort of what that meant for the parent experience in treatment?
Sure. Yeah. Yeah. So what I will say, just as a caveat, is that I'm going to be talking more about clinician reports to me, because we haven't gotten as much direct. We haven't collected formal feedback from the clients as of yet. It's been more clients sharing with their clinicians, but in terms of what I know, it's more about the clinicians' impressions of how things have been working. And certainly with the youth, there have been a number of themes that have come up for the clinicians using MBC with our youth, in terms of it being one theme actually that's been really interesting for some of our youth that have learning disabilities or differences in their ways of communicating and neurodevelopmental differences. That for some of the youth, it seems to be it can be almost an easier way to communicate about how they're doing, or how their symptoms, how they're feeling, how they're functioning, what their symptoms are like, than having the more traditional sit down where you say, okay, how are you doing this week? And you have to speak and look at your therapist in the eye and start talking about how you're feeling. They're actually finding it can mediate a little bit of that discomfort, and allows them to share in a more forthright way than they might otherwise have. There's also themes that I've heard about this just being a really great way to structure your session, in the sense of allowing conversations to come up about things that you might not have asked otherwise. So a youth who's never had any history of maybe self-harming or suicidal ideation, however, after a certain number of months of doing MBC, they report that. And then having it's a catalyst for your conversation. Like, why is this coming up now? And being able to have some more in-depth conversations about those things. And there's been youth that would say, I just didn't feel comfortable telling you till now. But, we've built a little more trust in our relationship. And now I feel like I can tell you, the truth about this. That could be one thing. It could be, actually, this is just coming up for the first time. I really didn't think about this before, but now we're catching it right away. So there's a few things of that nature that there have been the clinicians have found some real clinical utility to using these measures.
Right.
And it really adds to their conversations or their ways of being able to target what's actually going on with the client that week or that month.
Great.
Yeah.
And I love those examples. We certainly hear often the example with adolescents in particular around suicidality and self-harm, and that there's in some ways a lower barrier to being able to report it on a measure outside of session or in a waiting room, and it can open up that conversation which might not have happened otherwise. And that one always stands out for me, given the kind of the safety and the risk associated with it.
Yeah, exactly. Yeah, no, that one's a really, of course, important area for us to understand. It comes up in other areas too, though. It's like, the youth who's never really reported sleep problems, and now they're suddenly, they're reporting very disrupted sleep for the week. And then that opens the conversation about, that seems to have changed for some reason, right? What's going on? Yeah. Okay, so I'll move on here to our next slide. talking a little bit about within each of these programs that we've been implementing MBC within, we've had a bit of a process for each of the programs. So within each program, we've spent months and months preparing and discussing with the clinical staff what would be the best option for that particular program in terms of what measures to use, what kind of domains are we trying to measure? Are we looking at therapeutic alliance? Are we looking at functioning? Are we looking at symptoms? When are we going to administer these? Is this going to be every session? With whom are we going to administer these? Is this every client you have? Is that feasible? Because sometimes our caseloads can have very, very different ranges of ages or presenting challenges. And then also we did spend quite a bit of time just troubleshooting and understanding how to use the EMHware Greenspace integration. Any new software and technology takes time to adapt to, of course. Maybe more so for us as clinicians, we're not really technologically inclined sometimes, so it takes us a little bit longer. I know for me anyway, it can. And then within each program, we try to really start small and make it a little bit less maybe intimidating or less overwhelming for the clinicians who would be implementing. So as an example of this, when we were starting with our first program with youth, we did start with the 12 to 18-year-olds who are self-reporting. But clinicians in that program do see youth younger, as young as 7, sometimes 8. It's usually the kind of lower limit for that program. So we wanted to have, so we didn't, it wasn't someone's entire caseload that started off using MBC. So it would be the first few months, they're working with the 12 to 17-year-olds in self-report. And then we started talking about, well, what are we going to do with the younger kids? What kind of measurement do we want to use there? And by that point, the clinicians were a little bit more familiar with Greenspace and the integration with the EMHware. So I think it was less daunting to do it that way, because then they could then add to, okay, here's the rest of my caseload or the younger kids. And we did in that program make a decision to have a parent report for the 8 to 11-year-olds. So that's an example of how we tried to make sure that we were really collaborating with and discussing with the clinical teams to understand what would make most sense to them, what would work best, and not expecting them to kind of change their entire clinical practice overnight. Okay, and then I think I've touched on some of these points already, but just developing this plan for MBC within each of our programs, because they are so unique and diverse, we do have to consider the different client profiles. We have to just consider the neurodevelopmental differences. We talked about this a couple of times now, but we do have a specialized program with youth who have learning disability diagnoses. And when you have a learning disability, it can be affecting directly your ability to read, for example. So we had to just be understanding of, okay, if this youth is not really able to read at a level that would allow them to do this measure on their own, what are we going to do to accommodate or to help? Individualized treatment planning with parents is quite different from individualized treatment planning with youth themselves, because the parents are sometimes, there are different considerations, and even with scheduling, you don't always have the same rhythm or cadence of weekly sessions with parents. It doesn't always happen that way. And then also I did talk about a little bit looking at how we're going to use MBC within programming that includes standardized evidence-based group work, or things that we're not going to just shift from session to session based on someone's measurement or someone's response on a measure. So what we're looking at next at CDI is just really continuing to support the clinical staff in building their skills within MBC. So right now we have, again, my good luck to have these psychologists working with me, and we are all supporting different clinical teams, whether it's in their team meetings or through team consultation. We're having, as I mentioned, we're continuing with our working group, but now this is more of a quarterly group where we can share learnings and learn from each other across programs. We're continuing to identify resources or make up our own training, resources as we need to. Back in the early days of us working on some of these education sessions, we had some fun doing role play videos together. And, how would I talk about this measure with my clients? And what if the two parents have completely different, scores on this measure, or, tricky issues that we would talk about and do some role playing with each other and with the staff. And then, of course, we do want to continue expanding. We've not done in terms of which programs we think can really benefit from using MBC. So we have trauma-focused services, we have more intensive services that we think could benefit, and we are continuing to plan and be thoughtful about how we might implement within those areas. And then finally, we are participating in a C4K-led project that is supporting efforts to evaluate MBC within our sector across Ontario, which is really, really great. And I think we're learning a lot from each other in that context as well. And it's hopefully something that can benefit child and youth mental health centers across our province and maybe across the nation. We'll see how it goes. And finally, we do need more direct input from the youth and the parents who are using measures at CDI right now, because we do want to understand, sometimes we as clinicians have an idea of what's going to be helpful, and it's not exactly aligning with what the youth or the parent is really looking for. Or, of course, we also have misalignment between parents and youth sometimes in terms of what they are hoping for from a service. But in general, we've had some really nice early feedback from our clinical staff, and there's been some positivity and openness towards using this as a new way of practicing, which is really hopeful. They talked about seeing it as valuable for progress monitoring, which is one of the main purposes that we see that we would hope people would see value in. And then the catalyst for conversations, I already alluded to this already, a little bit before, allowing certain clients to have stronger engagement with us has also been reported by our clinical teams. And we still have a long way to go. So I really think of this as a very early stage, actually, at CDI. We've been working on it for years, but really there's still far to go. So we want to understand more about how parent report measures work within parenting interventions. There's not a lot in literature and the research about that yet. And also just clinical care with clients. If they are really struggling to participate in MBC, it's rare. We don't have that's not like a huge proportion of any of our clients at all. But when that happens, just figuring out how to help encourage people to participate and not just stopping suddenly because someone is a little, says, I don't want to fill out the measure today, doesn't mean that we put it aside. So there's a few directions that we're going to be going in. And finally, I think Lori has a couple of, just to talk a little bit about key learnings.
Yes, thanks, Nora. I just want to also just say that Nora just mentioned it, is that we're very, very fortunate that there is a high level of motivation to implement MBC in our clinical services. We're so very blessed that way. And it was interesting in our work with Capitalize for Kids, we did issue a change readiness survey early on before we actually really had socialized MBC. And that was one of the areas that actually showed fairly strong, even though people didn't necessarily know what exactly MBC was. There was an interest and a real motivation. So we're very fortunate. But I just thought I'd just take a minute to share some high-level key learnings in terms of what are the elements that make for a successful implementation. Definitely being championed at a senior leadership level. Early in the process, as an example, we had a visioning session that Capitalize for Kids facilitated with our senior leadership team, and we developed MBC statements, both for internal audience as well as for our users. So that helped to kind of anchor it for us at a very senior level as an organization. The other is strong change management strategies and project management. And again, we have been working shoulder to shoulder with Capitalize for Kids, who have been instrumental in providing project management, helping us with process mapping and all of the, we have access to subject matter experts. That kind of support has been really quite tremendous. And of course, the technology, I mean, we've talked about that. I mean, having the integrated client information system with an MBC system, having equipment such as tablets and iPads. Whenever we have a little bit of extra surplus dollars, we purchase some more, and we're finding that really has reduced the barriers to completion of measures right in sessions in our service centers. The other is the clinical acumen, and certainly a real credit to Nora and our clinical psychology team. Also, our clinicians who are primarily social work registered clinicians, and the access to subject matter experts has really been a strong support to making this successful. The other piece is clinical supervision, the training, and the active involvement of the staff in the process. Nora was describing how we've been very involved with, working groups and training and having those opportunities for conversations for people to share some of the challenges, some of the tricky issues, but also some of the successes. So really bringing all of the staff at every level involved in the process is really a key to success. So that concludes our part.
Thank you, Lori and Nora. We have 5 minutes left here. I'm going to do my best to coordinate the Q&A, and I've bucketed them into a couple of categories. I think the first one that has the most upvotes so far on my screen is, and there's a couple questions related to it, but for Nora and Lori, if you want to share a little bit about what measures CDI is using, that seems to be of interest to the group here.
Sure. I guess I'll just stop sharing, right? Because we don't need the screen.
Okay.
So for our youth program right now, we're the one that has their self-report for 12 to 18. They are using the GAD and PHQ, GAD 7, PHQ 9, which are very brief measures of anxious and depressive symptoms. So it's kind of a symptom-focused measures. It depends on the youth, because there are other measures that sometimes are being used depending on the youth profile, such as the, I'm forgetting the exact name, but I think it's it's a suicide ideation screener.
Or maybe the Columbia Suicidal
Severity
Rating Scale?
Yeah, not California, Columbia, that's right. Yeah, thank you. And then depending on again, there can be other measures that are used depending on the client's profile, but the PHQ and GAD are the regular session by session ones. The ones that we're trying out with the parents for the youth is called the emotion dysregulation inventory. That one is not really used in the MBC literature, to my knowledge, but Carla Mazevsky is the author of that one, I believe, emotion dysregulation inventory, and it really is a general measure of how reactive the child's emotional state seemed to be, or how dysphoric, so if they're kind of withdrawing. That one we're also trying out in our youth and the program with the parenting with the very young ones, 0 to 6-year-olds, the EDI. And with our group program, we are the post group MBC work we're doing. We're trying out the EDI actually for parents, and then the child outcome rating scale. So part of the PCOMS measure, the ORS for child self-report. Mm-hmm.
Yeah, thanks, Nora. And I'd follow up for those that are interested. Greenspace obviously has pretty good insight to what's being used across the country in different programs and levels of care, and that's often part of implementation, is being able to share, hey, this is what we're seeing used really well. Here's what we've seen for psychometric properties, and I think like Capitalize for Kids, particularly in the child and youth sector, is going to play a bit of a role there in Ontario as well, in trying to kind of create a bit of standardization and a data set associated with it. So I'm excited for all of that work as we move groups towards kind of shared best practices. I think there's a real opportunity for what that data can look like together. I'd say that there's several questions specific to the Greenspace and EMHware integration, and a number of which were upvoted. We only have a few minutes, so I'm gonna do my best to give like a quick integration overview. I've pulled up a net new slide and a bit of a picture of where this is going. But what I would encourage everybody to do, if you wanted to ask questions specific to your organization, specific to your workflows, to connect with the EMHware and Greenspace team to go deeper and talk about your organization specifically, and that'll, I think, give them a lot more opportunity to get into the details. The very quick overview, because there was a lot of questions, I do want to answer it live. Um, the core integrated flow is focused on reducing clinician effort and any duplicate data entry. So the core flow automates client creation and updates. So when you are creating a client, assigning them to a program or another sort of trigger on EMHware, that client gets set up in Greenspace. On the, the Greenspace side, you're managing assessment, delivery, and completion. There's a whole range of different methods. And then when those measures are completed, the results are coming back into EMHware as a visual document. And you can click in through that to access more interactive results within the Greenspace application. A major change that is coming that we are really excited to roll out is a browser extension on top of that integration. And so think of a side panel overlay that's accessible on top of EMHware that allows some of the key actions that users might want to do, like adjusting assessments or archiving a client or reviewing results, allows that to happen from the sort of pane of glass of EMHware. And so really improving that clinician experience, where today, if they wanted to, if a clinician had to adjust assessments, they move over to Greenspace application to do so. What we're rolling out right now is an ability to do that without leaving that context, with single sign-on supported. So there is not a separate login for clinicians, but they're already signed in through the external identity provider of the organization. So I'm going to pause there. That was a very brief overview. And I know we're right up against 2 o'clock Eastern here. And so, Sam, I'll turn it over to you to help wrap up, but happy to have our teams get into more detail for each organization.
Yeah, I love how succinct that was on also like doing like an impromptu feature launch on the webinar. So thanks everyone for showing up. You got a little sneak peek, which is fantastic, and a huge thank you to you, Lori and Nora, for being so thoughtful with how you shared your experience, sharing it in a way that is gives people insight on how they can make the changes that you have made within your organization. A few things that really stood out to me throughout the presentation was the kind of shared philosophy on the technology side of supportive rather than prescriptive. There is funding to support some of these initiatives. Reach out to EMHware and Greenspace. We work with so many organizations. We know a lot of these pots of funding and really want to share that information as we can. Lori, I love that you called out using MBC to support professional development, so the clinicians are more engaged as they start to see the progress of their clients going through and how they can make adjustments. The intentionality and the focus on organizational buy-in to run the project. There's just so many things that I could call out, and I know I'm running up against time too. So thank you everyone from joining. There will be an email that comes out after that will have a recording. There's also a survey that will help us all tailor to make sure the information that is most valuable is getting out. And if you do have any questions about EMHware, Greenspace, the integration, what the workflow looks like, funding opportunities, all of that good stuff, reach out to your EMHware AM or Greenspace CSM, or the EMHware support team if you're not sure who on the EMHware side is your go-to at support@emhware.com. So everyone have a great day, and thanks for joining.